In this lecture, we are going to cover sickle cell disease. Sickle cell disease is a group of an inherited autosomal recessive disorders characterized by an abnormal form of a hemoglobin in the RBCs. Because this is a genetic disorder, sickle cell disease is usually found during routine neonatal screenings. Although medial survival can now exceed 50 years old, sickle cell often results in irreversible damage of the lungs, kidneys, brain, retina, or bones that it significantly affects patients' quality of life. Right. So the etiology and pathophysiology, really what it comes down to is in a sickle cell, they are not formed like round with a little dollop. That's how I usually describe it, like a dollop in the center. They are formed like an S. And so they have long and flexible chains, and it alters that shape. The sickled RBCs can become stuck in the capillaries and they occlude the blood flow because they're not round and they're not able to just kind of go through um, the the blood vessels very well. They'll end up kind of getting lodged in there, which in fact causes this where it occludes it, and then that area where it has occluded, it is not getting the oxygen rich blood in which it needs. It is transmitted through a recessive genetic defect, and I think it's noteworthy that if both parents have the trait, then with each pregnancy, the risk of having a child with the disease is 25%. So that's pretty high. So there's different types. There's the sickle cell anemia. It's the most severe, and that is inherited by both parents. Um, uh, Sickle cell thalassemia, and then we have sickle cell hemoglobin C disease and sickle cell trait. The most that we're going to really talk about has to do with the sickle cell anemia. I think this image gives you a pretty good indication of what the differences look like. So you can see the normal hemoglobin on the left, and then on the right, you can see the sickle cell hemoglobin that forms these long chains. So they become rigid and take on this elongated crescent shape. They cannot easily pass through the capillaries or other small vessels, and they can cause the vascular occlusions, leading to an acute or chronic tissue injury. The resulting hemostasis promotes a self perpetuating cycle of local hypoxia, deoxygenation of more RBCs, and more sickling. Circling sickled cells are hemolyzed by the spleen, leading to that anemia. The main trigger of sickling episodes is low O2 in the blood. Infection is the most common cause of hypoxia or deoxygenation of the RBCs. Other causes include high altitude, emotional or physical stress, surgery, and blood loss. Events that can trigger or sustain a sickling episode include dehydration, acidosis, increased plasma osmolality, decreased plasma volume, and low body temperature. At first, sickling is reversible with reoxygenation. It eventually becomes irreversible because of cell membrane damage from resulting sickling, which it's from recurrent sickling. Vaso-occlusive phenomenon or hemolysis are the clinical hallmarks of sickle cell disease. Sickle cell crisis is a severe, painful, acute exacerbation of RBC sickling, causing a vaso-occlusive crisis. As sickling cells impair blood flow, vasospasm occurs, further restricting that blood flow. Severe capillary hypoxia causes changes in membrane permeability, leading to plasma loss. Hemoconcentration, thrombi, and further circulatory stagnation. Tissue ischemia, infarction, and necrosis eventually occur from lack of O2. Shock is a possible life threatening consequence because of severe O2 depletion of the tissues and decreased circulating fluid volume. Sickling cell crisis can begin suddenly and persist for days to weeks. The effects of SCD vary from person to person. It's individualized. The severity may be due to genetic variants. Many people with sickle cell anemia are in fairly good health most of the time. However, they may have chronic health problems and pain from organ tissue hypoxia and damage. The typical patient is anemic but asymptomatic except during sickling episodes. Because most people with sickle cell anemia have dark skin, pallor is easy to detect. It is easy to detect by examining the mucous membranes. The skin may have a grayish cast. Because of the hemolysis, jaundice is common. Patients are prone to gallstones. The main symptom associated with sickling is pain. They have severe pain, and it can range from minor, where it's not as bad for that patient, and again, it is the perception of that patient, to excruciating pain. During a sickle cell crisis, the pain is severe because of tissue ischemia. Whenever somebody has pain, and I think about this even when somebody has a myocardial infarction, so a heart attack, the pain that they feel within the chest is because of the occlusion that the oxygenated blood is just not getting to that organ. It is the same case with sickling, right? So you have that it's the pain is due to that ischemia. The organ is calling out, I'm not getting the nutrients I need. I'm not getting the oxygen I need. The episodes can affect any area of the body or several sites simultaneously. The back, chest, extremities, and abdomen are affected most often. Pain episodes are often accompanied by other manifestations such as fever, tachypnea, hypertension, nausea, and vomiting. So, this image taken out of your textbook really does show some of the clinical manifestations of sickle cell disease. So, it can, it can have thrombus or hemorrhage in the brain. You could have sensory defects, or it could be death. In the lung, you can have pulmonary hypertension. They can have pneumonia, kidneys. They can have blood in the urine, hematuria. They can have renal failure. They can have in their eyes. They can have blindness, retinopathy. Heart can be heart failure, spleen. They can have that enlarged spleen area, and then in the penis, they can also have something called priapism, and I actually had a patient that had this before, and it's a very emergent situation because you have to really think about the age, which most of these people can have uh, sickle cell crises during their younger years. My particular patient was about 18 years old. He was accompanied by his mother, and it was about the third episode that he had come in with this priapism. And what it is they have an erection that lasts for a very, very long time. The cause for concern is we know that that pain is due to an occlusion, and so the amount of time before that occlusion is opened up, you can have necrotic areas because of the ischemia. It's so it is an emergent situation that we need to get the blood flow back. And specifically, I think about for a young man who's in his adolescent years, 18, and he's moving into adulthood. This could cause problems with later on his life and his sexual experiences and that kind of thing, and maybe having a family later on. So it is an emergent situation. The pain is very much a problem. We need to make sure that we control it, but we also need to do whatever we can to get them into surgery or whatever the case needs to be, so we can open up that occlusion and they can get blood flow. So, some sickle cell disease complications. With repeated episodes of sickling, there is a gradual involvement of all body systems, especially the spleen, lungs, kidney, and brain. Organs that need large amounts of oxygen are most often affected and form the basis for many of the complications of sickle cell. Infection is a major cause of mortality. One reason for this is the spleen does not phagocytize foreign substances, so it doesn't break it down, doesn't eat it, and get rid of it in the body. It becomes infarcted and dysfunctional from the sickled RBCs. The spleen becomes small from the repeated scarring. Pneumonia is the most common infection. Infections can be so severe that they cause an aplastic and hemolytic crisis in gallstones. A plastic crisis can be so severe that it causes a temporary shutdown of RBC production in the bone marrow. Acute chest syndrome is a term used to describe acute pulmonary complications that include pneumonia, tissue infarction, infiltrates, and dyspnea. Pulmonary infarctions may cause pulmonary hypertension, MI, or poor pulmonale. The heart may become enlarged and ischemia, leading to heart failure. Retinal vessels, retinal vessel obstruction may result in bleeding, scarring, retinal detachment, and blindness. The increased blood viscosity and the lack of O2 can injure the kidneys. Renal failure may ultimately occur. Pulmonary embolism or stroke can result from thrombus and infarction of cerebral blood vessels. Bone changes may include osteoporosis after the infarction. Chronic leg ulcers can result from hypoxia and are especially prevalent around the ankles. And then, of course, like I was talking about, the priapism may occur if penile veins become occluded. Some of our diagnostic studies, we have the peripheral blood smear, hemoglobin electrophoresis, skeletal x-rays, MRIs, Doppler studies, and chest x-rays. Peripheral blood smear may reveal sickled cells and increased abnormal um, reticulocytes. Hemoglobin electrophoresis can determine the amount of the S, right, the crescent shaped RBCs. The accelerated RBC breakdown gives the patient the characteristic findings of hemolysis, so jaundice, high serum bilirubin levels. Skeletal x rays show bone and joint deformities and flattening. MRI can diagnose a stroke caused by blocked cerebral vessels from sickled cells, and Doppler studies can assess for a DVT. A chest x ray can diagnose an infection. So, some of our interprofessional and nursing management on the goals for the patient, right? We want to alleviate any of the manifestation or complications. Anything specifically, I'm going to tell you a lot has to do with pain and oxygen. So we want to minimize any type of end organ damage, continuously assess for and promptly treat any type of serious sequels that happen. Hospitalized patients in sickle cell crisis, definitely the O2 therapy. It helps to treat that hypoxia and controls that sickling. We want to do some really good respiratory assessments and assess for any changes in that respiratory status. We want to make sure we have a SCDs on this patient, that we are doing any type of like Lovenox so that we can try to keep from having any thrombosis, um, uh, pain, medication, additional fluids, and then transfusion therapy if that is so necessary. Professional and nursing management. Use a holistic approach to address the pain and its impact on the patient's quality of life. Patients may have different types and sites of pain, as well as acute and chronic. Undertreatment of sickle cell pain is definitely a major problem. These patients may develop tolerance. They may need larger doses of pain medication to reduce pain to an acceptable level. Pain can cause patients to have central sensitization, hyperanalgesia, and altered opioid metabolism. This can cause mood and emotional problems. During an acute crisis, optimal pain control usually includes large doses of continuous opioid analgesics along with breakthrough analgesics. Adjunctive measures include NSAIDs, anti neuropathic pain drugs, so antidepressants or anti seizure, local anesthetics, or nerve blocks. Occupational and physical therapy can optimize functioning. Sometimes we might need to have a chaplain come in if that provides comfort for the patient, and that can also help us with any to address any social, emotional, and spiritual needs. So we really want to look at them as a holistic all the way around. We want to, of course, um, minimize the amount of pain that they're feeling, but they may also need to get. Maybe they don't have a lot of information. Maybe this is the first time that they've had this episode happen, a crisis to where they're in the hospital. So we want to make sure that we consult other members of the multidisciplinary team so that we look at the patient as a whole. And if they need some emotional support or spiritual support, we need to also provide that to them. Frequent complication. Any febrile illness in a patient with sickle cell is an emergency. Wound infections, such as chronic leg ulcers, may be treated with rest, antibiotics, and proper wound care. Patients with acute chest syndrome receive broad spectrum antibiotics, oxygen therapy, fluid therapy, and exchange transfusions. Blood transfusions are done sparingly between crises because patients develop antibodies to RBCs and iron overload. Because chronic hemolysis results in decreased folic acid stores, the patient should take an oral folic acid supplement. Various drugs can reduce sickling episodes. Hydroxyurea increases the production of RBC and alters the adhesion of sickled RBCs to the endothelium. The increase in hemoglobin F is accompanied by a reduction of hemolysis, an increase in hemoglobin concentration, and a decrease in sickling cells in painful crises. We have, I think it's Advio reduces sickling cell and blood vessel adhesion, and Volexator stabilizes an oxygenated hemoglobin cell, reducing sickling. So there's different things that we can give as far as medication to try to prevent some of that from happening. So it's important that we, again, individualize this plan for each individual patient. Patient teaching and support are important in the long term care of a patient with sickle cell. The patient and caregiver must understand the basis of sickle cell and the reasons for supportive care and ongoing screening tailored to SCD manifestations. Teach the patient ways to avoid crises. Review steps to avoid dehydration and hypoxia, such as avoiding high altitudes and seeking medical attention quickly for counteractive problems, such as upper respiratory infections. Teach patients to maintain adequate fluid intake. We're going to talk to them about routine immunizations, pneumonia, influenza, hepatitis, now COVID. Screenings for retinopathy should begin at age 10. So they need to be instructed about making sure that they follow up every year with an eye doctor and get screened. Each person with sickle cell should have a reproductive life plan. This is important. They need to check and see, are they going to carry the trait? Is it going to get passed on to their offspring? Provide teaching about pain control because the pain during a crisis may be severe and often requires anesthesia. Minor pain episodes that are not associated with an infection and other symptoms that need medical attention can sometimes be managed at home. So we're going to give them signs and symptoms of that occurring, some changes. When should you start medicating? That information is extremely valuable for not only patients, but also for their caregiver, their family members, so that they know how to try to help prevent these crises from occurring. When when you review this, PowerPoint, I'm not gonna play this video for me to put it on through the recording, but this does talk about a, particular patient's journey. It's a short video on some of her things that she has encountered as a sickle cell patient.